You talked about the thumb joint.
Yes.
They say it's called slack. Is that the type of thing you're talking about?
You can try. It's a risk damage, so yes, you can try the procedure again. I can't be more specific without knowing for sure what's going on with your joint, but in general, yes, it's a possibility. Yes.
What about the current joint replacements, like for your smaller joints, like your hands?
What kind of question? What is that?
I mean, is that something that's recommended? I know that they have them available.
Well, it's like, again, if you talk to a surgeon, that will be your first offer, right? To go and get the joint replacement. So my point is, your joint is better than any of the artificial joints unless it's still functional, right? If you're losing function and the pain is uncontrollable by any other concerted efforts, then it's time for replacement. That's what I tell my patients, you know. I don't care about your anatomy. If your anatomy is the worst in the world, but you don't have any pain, and you can walk around, what's the point of a knee replacement? But if we do whatever we can, and your joint is still painful, and you cannot sleep, and you cannot work, and you cannot enjoy your life, it's time for the knee replacement, right? So it's a practical approach. When I go to orthopedic surgeon, typically they show you the picture of the joint. Look how bad is your anatomy. It's time for the joint replacement. That's not the right thing to do. Yes?
For CMC joint arthritis, when you start the hyaluronic, the Uflexa injections, is there a protocol for that joint as far as the number of injections?
Yes. So for the first CMC joints, typically, again, it's 3 injections on a weekly basis, once a week times 3.
And how long are they immobilized after the injection?
A day?
Just one day?
Just one day. So you need to have a thumb spleen typically for that. And typically, most of the hyaluronic acid injections last around 6 months. So, and then you need to repeat it again.
So how, are there head-to-head studies to show whether those injections are superior over steroid injections into the joint?
It's a very good question. So, well, first of all, steroid injections work for a much shorter period of time. So typically when you inject steroids in the first CMC joint, the expectation is 2 or 3 months, right? So that's number one. Number two, because it's a very superficial joint, you are at pretty high risk of having subcutaneous fat atrophy after the injection. So that's the main problem when we inject small hand joints. So you lose your fat under the skin, right? And once it's happened, we cannot inject the joint again because you may end up with ulcer of the skin, right? So the next question is how many times you can inject the small hand joint? 3 or 4 times a year max. And again, you cannot do it continuously. With hyaluronic acid, no limits. So you can inject for as many years as you want. I have patients in my clinic who I've been injecting for 15 years.
Wow.
And so they're still doing well.
But why not just get a replacement?
Well, again, replaced joints, first of all, they're much more prone to infections. So they're not perfect joints because your range of motion will not be back to normal. So, and then if you're very active with your hands, for example, the joint will last 5 or 10 years and then you need to replace it again. So, again, if you're willing to do surgery, the knees, again, it depends on your activity. Right now, 15 to 20 years typically, but again, it depends on your activity, it depends how active you are. Remember, that stuff doesn't regenerate. So once the damage is damaged, so it needs to be replaced, right? The cartilage and the bone can regenerate, but not the artificial joints.
Is the hyaluronic acid and the steroid injection something different?
Yes, they're completely different.
Oh.
So hyaluronic acid is a natural lubricant, right? So your body makes hyaluronic acid, and so it basically, hyaluronic acid injections, they give you 3 different things. So number one, they cover the surface of the bones and cartilage, right? So they improve mechanics of the joint, so that's number one. So number two, they stimulate production of your own lubricant. And number 3, what they do, they also possess some anti-inflammatory activity, they reduce inflammation, right? So when you use steroids, first of all, these are artificial products, right? And they decrease inflammation in the joints. They don't do anything else. Yes.
What's your approach for DIP, osteoarthritis, when that's horribly, horribly painful? The patient has bright red, swollen.
It's a very good question. So, so DIP meaning distal interphalangeal joint, right? So what do we do for that? So first of all, we do some workup because a majority of patients with the DIP osteoarthritis, they have gout, pseudogout, and psoriatic arthritis, which is hidden, right? So again, probably 30-40% of patients, they deal with gout, and when the joint is hot, right, it means that you're dealing with creaseful deposition. disease. So first of all, we need to rule out these problems, right? So if you're dealing with so-called primary osteoarthritis, these are osteoarthritis which affects your distal joints, so the drug of choice will be Plaquenil. So Plaquenil is not officially, but again, among rheumatologists, is approved to treat distal interphalangeal joints osteoarthritis in acute phase. It does work well. It doesn't work right away, so you need to be patient. So it takes around 2 or 3 weeks before it starts working, but at the end,
Is that a biologic or an immune?
no, it's a disease-modifying drug.
Okay.
It's basically anti-malarial antibiotic, right? What it does, it changes pH within your cells. It makes your cells alkaline. And so, but traditionally, that's the drug of choice for patients with distal interphalangeal joint osteoarthritis. The other approach, which we're using once in a while, is Voltaren gel. So, and you do Voltaren gel under occlusion. So what it means, you put the gel, put saran wrap around, and do it 2 or 3 times a day. After a week, the inflammation subsides down, is guaranteed. But then you need to use something else, like a Plaquenil, for long-term maintenance. Yes.
I was getting steroid injections in my SI joint,
Yes.
and it was helping my hip pain.
Yes.
And then my doctor said I don't want to do anymore because the side effects.
Well,
Yeah.
with steroid injections, you're limited how many injections you can do on an annual basis. So the limitation typically 3 or 4 injections per given joint.
But this, could I do this higher?
Hyaluronic acid doesn't work for SI joints. No, I'm sorry, it doesn't work well.
Okay.
So PRP works for SI joints quite well. We didn't talk about other things. So there's another branch of therapy. It's called prolotherapy, and I don't know if prolotherapy. Prolotherapy. So prolotherapy was invented in Texas in the 50s, and so the base of the therapy is injecting an irritant in the joint, which kind of causing inflammation, and then eventually it tightens the joint, so it causes a kind of very, very rough scar tissue within the joint. And so prolotherapy works quite well for the sacroiliac joints. Yes.
How can you reduce inflammation?
Where? Systemic
Everything is related to inflammation.
Well, you need to have a workup done to find what's the source of inflammation and then target it. So it's a very abstract question. So, but again, if it's a localized inflammation, then you can use steroid injections and other things, physical therapy. If it's systemic inflammation, it's a completely different ballgame. Yes.
If you have osteoarthritis in, here's my knee, what are my chances of getting osteoarthritis in all of my other joints?
It's a very good question. So there are no any specific studies. So the only studies which were done on patients with primary osteoarthritis. So it's an osteoarthritis which affects your hands, right? And it's a disease which mainly affects women. So what's been shown that if you have primary osteoarthritis which starts in your hands, you have around 70 to 80% chances of having osteoarthritis in the knees, and then your C-spine, cervical spine, right? If you have an osteoarthritis in your knees, so the question is, what is the nature of osteoarthritis, right? Because it may be due to the trauma, and then you have very minimal risk of having the spread of the disease to other joints, unless you traumatize other joints, right? If we didn't talk about that because of the time limitation, but there's a large group of conditions which call post-inflammatory osteoarthritis. So meaning that you have inflammation of the joint, the inflammation burns out, and you end up with osteoarthritis, right? Then the same inflammation can affect other joints, then the chance is pretty high. So before we do any procedures in our clinic, so we typically do a pretty thorough kind of workup to find out whether you have just mechanical issue or whether you have some underlying like gout or pseudogout or some low-grade inflammatory condition. All these things need to be addressed before you actually treat the affected joint. Yes?
I have osteoarthritis in my knees. I have one replacement and one that may or may not need replacing. My pain is at night. Why do you think I have
Okay,
it?
it's a very good question. So patients who have presumable osteoarthritis of the knees and nighttime pain, so why do they have that, right? You need to be tested for gout. So the most common cause of joint pain at nighttime is gout. Yes, and remember that gout can affect not only your feet, but it can affect actually any joint in your body. And the last presentation at the American College of Rheumatology this year in San Diego actually showed that gout may be a poorly recognized source of low back pain as well, especially nighttime low back pain.
Thank you.
Yes.
Is there any benefit monitoring sed-rate and C-reactive protein for people who have osteoarthritis? Not the other?
Absolutely, because in general, if you're talking about classical osteoarthritis, right, then sed-rate and C-reactive protein should be normal. So if these markers are up, you need to do some workup for an inflammatory component, right? Yes.
I noticed you work with physical therapy quite a lot.
Yes.
Do you think that there's benefits to massage as well?
Absolutely.
Okay.
Absolutely. So it's basically part of manual therapy.
Right, that's what I was
Yes,
wondering.
yes, absolutely.
It was I'm a massage therapist,
Yes,
and I work
absolutely.
a lot with
Yes,
patients
absolutely.
with arthritis. So.
Yeah, again, I didn't go into details, but again,
Yeah.
massage is part of manual therapy, absolutely.
Okay, and then the laser, I've had laser on my knee. I had 6 treatments, and it's phenomenal.
Yes,
It's
absolutely.
like I have osteoarthritis in my knee, and it's just
Yes.
amazing. So
Yes.
I always advise people to get that. And a lot of physical therapy clinics and chiropractors actually now have laser therapy.
Most of them it's a trend. They have cold laser, not a hot laser. And so,
I got the hot laser though.
yes, it makes a huge difference. When you're
Yeah.
using cold laser, it's kind of so-so. If you use a real hot laser, and also we have a laser with massage head, so we can do laser
Oh,
massage.
right.
So it makes a huge difference,
Yeah.
absolutely.
Is the laser therapy that you use, the class 4 that you described, is that the one that can irritate your eyes and you have to wear sunglasses?
Yes,
Does it
absolutely.
look like that?
Yes,
Fine.
yes.
Whereas the other laser that you're referring to does not require?
Doesn't require,
Okay.
yes. Yes.
Can you use laser to treat heel spurs?
Yes and no. So basically, typically for heel spurs, we're using, in general, iontophoresis, which I described, because we can dissolve heel spurs with acetic acid and ultrasound. And so laser is a part of the therapy. It's not like a solo therapy where I use laser exclusively, but in combination with other things, yes. Yes. So, yes.
Are 3 treatments of PRP the normal procedure?
It's a standard procedure, yes.
Standard procedure?
Yes, yes.
I mean, I've had one shot.
I-
It's been 5 weeks.
So again, I don't expect to see any benefits from just one because typically we don't see anything. If anything, actually, the first injection can make your symptoms a bit worse. It's normal.
It didn't as it happened.
Right.
but-
Because you trigger kind of an inflammatory reaction initially with PRP. And so even though if you're using super pure platelets, you're going to end up with a little bit of inflammation.
What about acupuncture? Do you have-
Acupuncture works well. Again, it all depends on the stage of your arthritis. So if it's an advanced stage, it's not going to work. If you have early stage, it will work. Yes, absolutely.
What causes bone spurs?
It's a very good question. So basically, there are a lot of theories about that. So in general, when you're losing cartilage, right, you create a cartilage defect, and your joint becomes unstable. So the bone spurs, to some degree, they kind of create an extra structure which will stabilize your joint. It's one theory, right? The second theory is that your bone, it's a live organism, right? So it grows constantly. So when you have defect in the cartilage, so the electrical kind of currency within the bone and the surface of the cartilage becomes kind of distorted, and that electrical current stimulate actually the bone growth, and the bone start growing in strange areas. So, but again, these are theories. No one knows exactly why it happens. Yes.
Is the gout, you mentioned my brother has severe gout in his toe, but I don't think I've ever had it, but I've had other pains. Is it still proven that it's due to your diet?
Well, gout has a very complex nature. There are a lot of subtypes of gout, right? But again, the treatment is very straightforward and very successful if it's done right. So the first step is to demonstrate whether you have gout or not, right? So in our clinic, we're using blood work for that. Obviously, it's a urine test, it's a blood work. And also, you can see crystals under ultrasound. So there's specific ultrasound signs for uric acid crystals, which we pick up all the time while we're doing ultrasound. Yes. Yes.
Do therapists require a prescription to use acetic acid without versus?
Well, in our clinic, physical therapy is part of the clinic,
Yeah.
so we kind of do it internally. So I don't know. So because most of our patients do therapy inside of the clinic, so right, and it's very inexpensive. It's very inexpensive. So electrodes are the most expensive than acetic acid.
Does insurance cover part of that, part of the Pilates?
It depends. If it's part of your physical therapy, then it's covered. Yes, because it's therapeutic exercises, right? Yes.
I had a hip replacement, I had heterotropic ossification for bone growth. Does the acetic acid, will that work on that?
No, because it's a very good question. So heterotropic ossification after hip replacement is very common, right? So most likely you had a hip replacement without irradiation, right?
Right.
Because these days it's almost a requirement to have irradiation after the joint replacement. So the ionophoresis will not work for one simple reason, because it's a very deep joint, and so acetic acid penetrates approximately 2 inches through your skin. So hip typically 3 or 4 inches, it's not going to work. Yes.
What do you mean by irrigation? You mean just water pumped into the,
Irradiation.
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 oh, irradiation?
Yeah, it's not irrigation, irradiation. No, it's pretty much universal requirement right now. So, but again, probably your hip was done a long time ago, right? Right. More questions? Yes.
Do you have a standard diet that you recommend for your patients with osteoarthritis that you say follow this particular type to reduce inflammation, avoid these?
If you look at the diet for osteoarthritis, it doesn't exist. So I hate to say, but for other forms of arthritis it does exist, but not for osteoarthritis. So the diet, it does exist for rheumatoid arthritis. So it's a proven diet and does work.